Okay. I've also realised that I've made a cardinal sin of both an educationalist and a presenter, in that when I looked at the number of slides I have to get through in a very short period of time, I am going to have to talk at a gallop. And it's because I had so much to tell you, but I will sort of go through some of the things quite rapidly, because I actually wanted to get to the point of guidelines, which is implementation. So I want to try and bridge the gap, if I can, towards the end. So I'm going to just briefly talk about, let's move away from the mic, the process of guideline development, give you some idea of the types of evidence that we have available, just highlight what the new recommendations are in the guidelines. Can I just take a show of hands? How many of you have either read them from JHI or looked at them online? Okay, so you all know where they are, and I'm literally just going to highlight some of the issues that have come about. Just think a little bit about what we need to do to try and improve the evidence base where we can, and then discuss implementation. So the process is based around essentially three modules of guidance around standard principles, not standard infection control precautions, not what Yvonne was talking about this morning, but standard principles for infection prevention. And I'm aware that perhaps critical language is something we need to get right. The use of short-term indwelling urethral catheters and the use of intravascular devices. Previous versions or iterations of the EPIC guidelines focused entirely on central venous access, and this iteration looked at peripheral vascular access and something around aseptic technique. The process I've done as a sort of a quick schematic, so I don't bore you too much. Essentially, every module starts out with a protocol. Every question has a protocol. We had a guideline development advisory group. We searched for guidelines to start off with, because we don't want to reinvent the wheel if there's evidence that's been assessed fairly recently. We use an international standard for agreeing those guidelines to see whether or not we can use them to move forward from. We then search for peer-reviewed studies, we sift, select, appraise, and we extract the data to come to some conclusions about what we should be recommending. We include a number of study designs. Unfortunately, infection prevention and control, we don't often have the luxury of cluster randomized control trials, RCTs. We're much more likely to find that we have interrupted time series or control before and after studies. And there are very few systematic reviews and meta-analyses for that reason of infection prevention and control studies. These are a couple of schematics, which I won't spend too much time about, but this actually helps us to decide whether a study actually is the type of study it says. And one thing I would say, anyone who is thinking of writing up their research or writing up their implementation projects, think very carefully about how you describe those studies, because that helps me as someone who's looking for the evidence all the time to actually find those. And I don't have to spend, or the team don't have to spend hours trying to work out, oh, is it one of those, or is it one of those? How did they actually do it? So try and look at standardized designs and decide which ones you're actually using. We used two sets of design criteria, one from SIGN, the Scottish Intercollegiate Guideline Group, but another from EPOC around looking at the interventions that happen at an organisational level. So we looked particularly at control before and after and interrupted time series designs, which are usually acceptable within that. We stuck with levels of evidence rather than using grade for this iteration. Should they, in my lifetime, come to be redone again, which I'm hoping that it's after I retire, because it's such a big job. We may move to a grade system which is actually being looked at, updated at the moment. So the ones with the crosses against are not levels of evidence that we actually would accept within the guidelines. So anything that's non-analytics, uncontrolled before and after, and just single, in single study case series reports is not there. It might inform expert opinion, but unlikely to do so at this level. So having done all that searching, appraising, pulling stuff together into tables, we then give it to a guideline development advisory group, which consisted of a number of experts drawn from areas of microbiology, practice, public involvement. So we had two members of the public working in our guideline development advisory group. And basically what we did was we looked at what the EPIC 2 evidence had said. We looked at what the agreed guideline and appraisal said. We took a patient perspective. We looked at regulation and legal requirements, and we drafted our guidelines. So it goes through quite a long process once we've actually pulled the evidence together. And having patient view is really, really important. Clearly, NICE always do that. We had previously done it and retained it in this iteration. So the guidelines, the recommendations have a classification, which actually give you some indication of what the level of evidence is. But it's not a level of evidence. You can't say, oh, it's only D, I don't want to do it. Okay, they're giving you some idea of what the level of evidence is that underpins that piece of guidance. And if you like, the rationale behind that is you need to know that, but the absence of RCT evidence doesn't actually mean we don't use the evidence that's available to us to actually direct practice. It might help us decide we need more research, or it might help us decide we need no research because we probably can't waste the money doing those sorts of things. Having drafted the guideline, it went out for consultation for around 6 weeks. It was then revised through the Guideline Development Advisory Group. So we as the researchers don't have any part in that process. We find the information for the Guideline Development Advisory Group to actually use. The revisions took place. It goes to the Department of Health, who actually commissioned the guidelines, both the last 2 times and this time. And we reached the final guidelines. Now, in order to get that into NHS evidence, in order to have it recognised as a guideline that's been developed in the best way it possibly can be, we then put the guideline through NICE accreditation, and I was really pleased when we actually got that, because it's very useful for you, because you know that actually it's not a NICE guideline, but it does meet the standard both nationally and internationally that is required for a guideline to be implemented. So it's really assurance for you as practitioners that we've done the best we possibly can with the evidence available to us. So what's new? So in hand hygiene, we had 5 questions. We had obviously available to us the WHO guidelines. We found another 250 odd studies. We appraised 80 of those. We only accepted around 17, and we came up with 3 new recommendations, not particularly based on terribly good evidence. But issues around local programmes of education, social marketing, so the multimodal approaches that we've started to use need to be refreshed, and that sort of is now a standard, I think, that is within the guideline. I think the issue of patient and relative information is really important, and also how to keep their own hands clean. We did look for evidence of actually how patients might be able to keep their hands clean when they're in hospital. Really poor evidence, very few studies, but those that there were showed that actually patients generally weren't offered the opportunity to clean their hands. And you know, there are issues around that, but clearly that's something I think we need to look at as practitioners, both on the front line and infection prevention practitioners. In terms of PPE, there were 8 questions. You can see how many studies we had. We just came up with 1 new recommendation, so nothing drastic to change that. And they were really around glove use based on risk assessment, and staff competence and education, and the availability of supplies. So those are the ones that actually came out. So in terms of gloves must be worn for invasive procedures and contact with sterile sites and non-intact skin or mucous membranes. And that's sort of rewording, really. So we actually tried really to get home when they absolutely must be worn. And I've just come from Jenny Wilson's session on, you know, glove use and how the way in which gloves are used could contribute to cross-contamination, cross-transmission. So I think it's really important that we try and start to look at this as an issue in terms of patients, practitioners' glove use. And also, it really impacts on hand hygiene. The use of gloves really does put a barrier around hand hygiene messages. People see gloves as no need to actually clean their hands. Single-use items, so again, reiterating, put on immediately before an episode of patient contact or treatment, removed as soon as that episode is completed, and changed between caring for different patients. The one sort of new identified element was the removal of PPE, and that came around following pandemic flu, and we've looked at how things should actually be removed. You can see all of this is Class D, so it's best practice, not the sort of thing you get money for an RCT for. NIHR would not be interested in giving us money to do these sorts of studies. So you need to think about, we need to know what's happening in practice, so we need to understand what people are doing, and then look at how we can make them sure they do it the best possible way to avoid those particular issues. We looked at aseptic technique because the Department of Health wanted to have something in this iteration of the guideline around that. So we had 3 questions. We used NICE clinical guideline 139, which is actually the community guideline, which was, I think, released the year before ours. We looked at 35 studies. We only appraised 1 study. And we didn't accept any studies at all. Now, that's not surprising, okay? It's a principle that we use. It's embedded in time. It's one of those things. It's a priori. Why would we not do these things? But we did actually come up with 2 new recommendations around asepsis. And I know people wanted us to say use ANTT. Okay, I know that was what the sort of the outcome might have been from your perspective. But actually, there is no evidence that ANTT is the best way to deliver training for aseptic technique. Okay? And Stephen Rowley and I have had quite long conversations around this. It's a very good way. It seems anecdotally to help people because it has certain processes, there's reliability built into it, but the studies underpinning that are slightly problematic. So these are the 2 new recommendations that come out. So it's really important that we do train people to be competent. How you do that requires some thought. ANTT is one way you can do it, but there are other ways as well. Short-term indwelling urethral catheters, we had 7 questions. You can see how we moved along from this. Our last guideline was the CDC guideline from 2009. We accepted 6 studies and we came up with 4 new recommendations. These are really to do with things that we knew worked but weren't in the previous guidance. So there's a particular issue around latex, and this came from patients in terms of latex allergy and ensuring that we know the patient's needs before we do it. The second is actually around ensuring that we change bags when clinically indicated or in line with manufacturers' recommendations and not just routinely, so we don't change them every night just because we fancy doing it because it's clean and tidy. So we actually only do it when we need to, so clinical indication. And that we really, really pay attention to the system interventions that we know work, so catheter bundles, and trying to ensure that people adhere to those, they stick to them really well. And I suppose that the end of this is actually sort of thinking around the discharge, because one of the things we showed in a study that IPS supported 2 or 3 years ago was that patients get sent home with a catheter which never comes out. So they didn't come in with a urinary catheter, they get one put in for a clinical reason whilst they're in hospital, and then they get discharged and people forget that they've got it in. They go home to a nursing home, or they go home to their own home. It never gets challenged. 18 months later, you've got a person who's actually had an indwelling catheter when they no longer need it, and no one questions it. So this, I think, was a really important recommendation. And I've actually got a student at the moment who's auditing this in community practice with some quite interesting sort of results. Intravascular devices, lots of questions. An enormous number of questions. The most recent guidance that we looked at was the CDC 2011 guidance. We retrieved 96 studies. We accepted 22 of the 30 that were appraised. And we had 9 new recommendations, most of which are actually to do with peripheral vascular devices. So the first is around education and being aware that we're using devices in an appropriate way that's related to individual needs, but also what happens in terms of what the manufacturers tell us. That in case for patients who need a medium-term intermittent access, then we move to peripherally inserted central catheters, so PICC catheters. Again, I think this is where sometimes, practice moves ahead of guidelines, but that is in many cases what happens, and because the guidelines haven't been revised, you haven't caught up, so this is now caught up with practice. CHG impregnated dressings should be used. We looked at HICPAC around sponge dressings, and we found one additional study to do with that. But that particular study didn't compare gel versus sponge. So we've considered the use of CHG sponge dressing in adult patients with central venous catheters. That may be one of the things we revise quite early, depending on what evidence actually comes out around that. I know there are other studies going on. We looked at chlorhexidine bathing, and you can see from this slide that there is evidence that chlorhexidine bathing actually helps us in terms of reducing intravascular device-associated infections. And so, again, it's to consider the use of daily cleansing with CHG in adult patients with central venous catheter as a strategy to reduce catheter-related bloodstream infections. CDC actually say do that as if you know the other things aren't working, they sort of add it in at the end, and that's why we've used consider. So it's not something you necessarily might always do, although I know that, again, practices that in some ICUs, that is actually the standard of care. Cutaneous antisepsis and peripheral vascular devices, so decontaminate the skin with CHG in isopropyl alcohol or povidone iodine if patients have a sensitivity to CHG, and before allowed to dry before inserting the vascular device. That is extrapolated evidence, okay? So that is, it works for central lines, it'll work for peripheral vascular devices. The same for dressing changes in terms of PVCs. And then replacement strategies. There's quite a lot of work around replacement strategies. So there is around using a visual infusion phlebitis score, and certainly the IV group within the IPS have been doing some work on a new tool to use, which I think they've been talking about in the last hour. So, that's important that we use those sorts of risk assessment tools, and that we actually should only recite when clinically indicated rather than on a ritualistic 72 hours, 96 hours. Now, that again is, I think in some places you sort of think, well, do we need to change our guidance? What are we doing? And it depends on, to some extent, how long lines might stay in. I mean, I'm not sure, but most lines probably don't get to stay in more than 3 to 4 days without needing a change anyway, but this is something that you should certainly look at, not routinely doing it for patient comfort reasons as much as anything else. And this is the evidence that demonstrates that reciting PVC is, it's on the basis of equivocal. You don't actually gain any benefit from it. The patients don't gain any benefit from it. And then the issues around system interventions. So again, that we really build in the CVC bundles and make sure that those are adhered to. Really probably one of our greatest success stories over the last sort of 3, 4, 5 years in terms of ensuring that those take place in ICU. So issues for the quality of evidence. So what is it that we still have problems with when trying to develop guidelines? It's around study design. Many of the studies that are done are convenience-based samples. They're often in single centres. They're often single before and after studies. They have interrupted time series with too few measures before and too few measures after for us actually to be able to say, well, that particular intervention had that particular effect over time, and we can see that the slope is decreasing. One of the issues is, again, trying to look at the heterogeneity of studies, where they're actually set. So is one ICU the same as any other ICU if what you've got are these single before and after type studies? The types of intervention, details around exactly what your intervention was, what the percentage of CHG was, how it was applied. Very difficult to assess, and we had to go back and do some real sort of trying to get to the bottom of exactly what had been done in a number of studies around that. And I think something we're probably really is a problem for us. We're trying to improve so much. We throw just about everything we can think of at a problem, but we don't really take account of those when we're writing up. Implementation studies are really important. We can learn from implementation studies an enormous amount. There isn't a huge methodological background to how we look at implementation studies, and I know that the Joanna Briggs collaboration are actually looking at how we can critically appraise this type of study in the same way as we critically appraise other types of study. But often baseline measurements are missing, and you need more than one. Measurement is often focused on process and not outcome, and I know that's difficult. I've tried to design them. Trying to find the outcome that you'll measure is not easy. And we have multiple interventions being rolled out at the same time. So if we look at implementation, how am I doing? Okay.
10 minutes.
Okay, the problem is that infection prevention and control is seen as an additional task. And I think that came up this morning, and it comes up constantly in terms of how we talk about things. It's not embedded in the real tasks that we undertake. You know, as a frontline ICU nurse, I often see, oh God, you know, I've got to do this, I've got to do that, and at the same time, I've got to make sure this patient is safe. And so that's quite difficult. The benefits aren't visible or immediate to us. So, you know, we don't often see that in cases. And also the harms are distant. So we don't see what happens to that patient, particularly in the UK. Our bed occupancy is huge, 110%. Patients are in, patients are out. Post-discharge surveillance may not actually get us and bring them back to see us. So, and they're often associated with sort of individual team and system errors. And staff develop what Carla Alvarado talks about as shadow systems. So they do things in a way that sort of just works around those particular issues that we're trying to get them to sort out. You're probably all familiar with Reason's human error, Swiss cheese model. We tend to focus on active failures, so we look at blaming you and you for not doing particular things, rather than looking at the system issues that could actually help us do things better. The healthcare system is made up of a range of things that we all have to negotiate in trying to implement best practice. So there are our patients, there are policies, there are procedures, there are the products we use, there are issues to do with the organisations within which we work, to look at things like the infrastructure that we have, so the buildings, and some of the peripheral issues around sort of structural things like regulation, etc. So if we look at some of those things in the things we have to think about when we're trying to implement guidelines, is actually think about, well, we now have patients with complex conditions, highly ageing population. They are increasingly knowledgeable. The point that DDA made this morning about having access to information is really important. We have patients who know sometimes as much as on a particular level as we do. And they're partners in care decisions. So the things that actually impact on that when we're trying to think about how we make patient care safe is we're often asking patients to look after themselves. That means we have to be able to give our messages in a way they can understand and they can actually comply with. We want staff to adhere, and yet the things around them often make it really difficult for them. The settings in which we're caring for patients are diverse. They're very different to the way they were. Yvonne highlighted, where we're actually going with that this morning. And we have, because we have an ageing population, we do have issues quite a long way down the line around mental capacity. Actually, how do we help patients and carers? Carers may be as old as the people they're looking after them at home. We need to think about some of those things as we're doing. So products and peripherals, you can tell from our exhibition, we are fortunate in many ways that we have a lot of technology that we can use. So we have access to technology that can help to make things better. So there's a lot of it. There's a lot of things that are the same but slightly different. They have features that we have to think about how safe are they. And we have to make sure they can be integrated into the work that people are actually doing. So the things we have to think about are the ward design, the location of those things. Jenny Wilson just identified gloves over there, out of the way, put them on before you arrive, you touch all sorts of things on the way, and, hey ho. Noise. Noise, I don't know, my mother died earlier this year, my father was in ITU. I have never been so aware of how noisy the healthcare environment is, how impossible it might be as both a practitioner and a patient to understand what you're being asked to do, to keep your minds on the job at the end of a 12-hour shift. It is so noisy, just unbelievably noisy. And that distracts us, it takes our minds off what we're doing. It's one of those things I don't think we really think about that much. So our providers, so who are the people we have to interact with within the system? So we have managers who take decisions sometimes without consulting us as the people who know things better. We have nurses, medical staff, our allied health staff, clinical support staff, technicians and patients. If you look at some of the work around ensuring that people are engaged in what we do, we need all those people to help us decide how we implement things best. Sometimes the porter is the person who can tell us something we don't notice. We're so busy focusing on the technical, we miss the things that are at the social patient interaction level. So there are things we need to think about. Our staff are highly mobile. You probably know that one time, twice in the year, you probably don't want to be in hospital when the new FP1s, FP2s in the UK come in, because, basically what you want is a really, really senior, well-experienced nurse in the area at that time. We have equipment that moves between different settings. We have different cultures within different parts of our units, because that's led by the people who are actually responsible for care and management and leadership within those areas. So there are a whole range of things we need to think about here. Procedures. We need clear, standardised, well-communicated, integrated into work procedures. This morning just sort of highlighted that, we're not using clear language. We don't have some of that consistent language that we can use. And I don't think it really came home to me until I listened to some of the talks this morning that that's the thing that is the problem. But we have this is the way it's done here, so you can be taught the right way, you can be really good up to the point you get into practice, and then someone tells you, socialises you into, actually, we don't do it that way here. This is our workaround. This is how we get around that. We have huge amounts of variation, and we have this interruption. Again, if you are watching, I was typical sort of researcher in me, sitting, watching whilst I'm next to my dad in ITU, just watching what people do. See who they're talking to, see what they do with their hands, see where equipment goes without being cleaned. And very like Jason Leach this morning, never said a word, because basically they're looking after my dad, and I want to make sure that I don't upset them. So, you suddenly become disempowered when you're on that side of the fence. It's really, really interesting. And I'm not a shy wallflower, as many of my friends will tell you. and I'm not afraid of speaking up, but you just change. So there are things you need to think about when we're looking at that, those sorts of things. And I think the last thing is sort of policy and guidelines. So how do we actually make sure that protocols, guidelines, regulation, inspection, sanctions actually work together? Because they add complexity. They're often top-down. They often have unforeseen or perverse consequences that we need to think about. They interrupt our real work. So actually following all of that can interrupt what we do. So if you actually think about the latent conditions rather than the people that we try and blame, there are issues around our organisational culture and policies, our team communication and shifting responsibilities, ensuring that we provide training, the fatigue our staff have, the distractions that they actually have to contend with. I really don't know how you can work 12 hours and be as fresh at the beginning of it as you are at the end. You simply can't be like that. And so the things we're trying to get people to do have to have those sorts of things built into them. Jason Leach again this morning said, you know, funding's not going to get any more. We're not going to get more funding. We're going to have to use the funding we've got smarter and better. So we have to think about which of the devices, which of the products that are actually on show at our exhibition can help us do things better, can help us do things smarter, give us the information we need automatically, so we don't have to continue collecting data around certain things. Thinking about technical poor design and maintenance, and actually how we design tasks to fit with that equipment. So if you're looking at error reduction, if you look at a human factors approach, the things that work the least effectively are the things we tend to do most of, which is we discipline people when they don't do it right. We give them a written leaflet that tells them how to do it, or we give them more education and training. The number of times say, well, actually what we need to do is do more education and training. But actually the things in blue perhaps have some effect, and they are the things we're looking at in EPIC, which is trying to do things on a simplified, standardised way, trying to give everyone the same message. Think about reminders, checklists, double check, and rules and policies. The things that work the strongest are forcing functions and automated computerization type approaches. Not necessarily the things we think about in patient care, used highly successfully in high reliability industries, so the airline industry, the nuclear industry, power industries, the oil industry, those sorts of things. So if you can design work so that people have to do it that way, you will get compliance and adherence, if that's the only way they can do it. So if you put things into a pack so everything is there, they have to do it that way. Okay? If you don't have gloves miles away from the patient bedside, you might at least reduce the level of contamination before they get to the patient. So think about how can you redesign work in order to make sure people are able to do the right thing easily. Because it's easier at the end of that 12-hour shift if you're forced to do it, if you don't have any choice. So our thoughts for the future. Basically, when we have bloodstream infection rates at a very low level, it becomes increasingly difficult for us to show that we have any more effect. So there are things that we sort of think about. And so we have to look at greater focus on the economic outcomes and demonstrating equivalence between the things that we think might work. Because that gives people choice. If people have choice, then that's helpful. CSR, BSI are not the only things that cause severe morbidity. And I think that goes back to our message this morning around politically, we have to try and keep the fact that infection is an ever-present danger. It's something that will not go away. It will come back. It will bite us in the arse yet again with something that we've actually missed along the line. So, we have to keep that on people's agenda. And we really do need to understand how people behave. We can only do that by watching people. We can only do that by being out there, really, really understanding about the context of their work, because it's different to the context of your work. So you really have to focus on that. Acknowledgements to the team who actually assisted and did a lot of the work, huge amount of work, in actually delivering the EPIC guidelines. So the appraisal team on the right-hand side and our guideline advisory group on this side. Thank you very much.